So welcome again to the ongoing series at Special Surgery entitled The Power of Pivoting, Managing Through Crisis, a discussion of the response at Special Surgery to the COVID-19 pandemic. I'm Dr. Ronald McKenzie. I'm an internist and rheumatologist at this hospital, and I'm the moderator for this series. So today we're going to talk about palliative care. Yes, you heard me correctly, palliative care at the Hospital for Special Surgery. And to have that discussion, I've invited Dr. Faye Rim, who is the medical director of pre-surgical chronic pain management in the Department of Anesthesiology. She's a trained physiatrist and also a trained palliative care medicine specialist. And Mary Kelly, a nurse practitioner here at HSS, who is the director of perioperative pain services. So welcome to you both. So Faye, I thought maybe because the audience may not really be aware of palliative care needs and services of special surgery, you could tell us a little bit about this department or area that you're in charge of. There's a committee, I believe, on palliative care, and we can then segue a little bit into the activities of the last 6 or 8 weeks.
So for those in the audience who don't know, palliative care is basically a service that provides supportive care. We are an added layer of support for both the hospital staff as well as patients and family. And what palliative care generally tends to do in the hospital setting is aid in the decision making, looking at goals of care, what is it that the family wants, what is it that the patient wants, what are the expectations of the hospital staff as well. And prior to the COVID crisis, generally there was not a big need for palliative care, thankfully. And I think that within the crisis itself, we have quadrupled the amount of consults within the past month that we did over the last 4 years amalgamated. The service prior to the crisis was a consult service by committee. And it was generally under medicine. There was a couple medicine attendings who were on the palliative care committee, as well as members of spiritual care, nutrition, social work, case management, and pain management, of which we were members of. And the way that the consult service worked prior to the crisis was that if a patient had been identified needing a palliative care consult, the request would go to the palliative care perfect serve, and it would go to every member of the committee. And then all the members would gather together, discuss the case, go see the patient, reach out to the family members, and then come to some kind of consensus as a committee in terms of what the expectations are for the goals of care, what the expectations are to trying to help make the patients feel comfortable, and where the patients were going to go. And again, it was one that was very time involved, labor intensive, personnel intensive. Clearly, with the volume of patients that were coming through and the acuity of the patients that were coming through with the COVID crisis, that kind of consultative service by committee just was not feasible. One of the issues we had was trying to decrease the footprint into the hospital. The others were that we didn't have a lot of the staff members or the committee members because they were doing work from home or on a rotation schedule. And again, just the acuity, the patients had to be seen quickly. And so a consult by consensus becomes very difficult to do. So what we decided to do was revamp the way that you called in for a consult. So we left the perfect serve consult available and decided to have it be triaged by an attending on the service. And again, most of our medicine attendings who were on the service were being pulled to do other things. So we really kind of dived more into who was available on the pain service. So it was myself and Dr. Hernandez who were in-house, as well as some of the outpatient doctors on 75th Street who were available to help out in this crisis. And so we had the consults triaged by a physician, to look at what the specific issues were, whether they were end-of-life issues, whether they were goals of care, looking at DNR, DNI issues, or if it was symptom management, a lot of which was pain, anxiety, agitation, which the pain service is clearly well equipped to take care of. And then basically trying to make sure that we identified appropriate staff members to be able to address those issues. There was a lot of family anxiety, so we used our social workers to reach out to the family members. Again, everything was by telephone, so it was easy enough to do to even have people who were working from home reach out to the family members. And then there was a lot of staff anxiety on the floors, the nursing, even among our critical care attendings and our medicine attendings. This was a patient population we are not used to taking care of. And even though everybody has trained to take care of this, the situation itself was very different and not our usual. So it was a lot of supportive care even to the hospital staff in how to manage and talk to family members and process their own feelings about what was going on.
And I think there was some interaction also with the bioethics committee, which I'm a member, so I'm aware of these interactions.
So there was a lot of interactions with the bioethics committee. I think that one of the issues is we really didn't have a need for palliative care or a lot of bioethics consults either. And so what's the institutional knowledge about how to handle withdrawal of care, what's the process for getting a do not resuscitate order, what's the process for end of life care. These are things that were there, but we never really had to utilize, thankfully. And so trying to make sure that the information was disseminated appropriately, we were still going by due process, what's necessary to make sure and ensure the appropriate level of care. And so there was a lot of coordination with bioethics in that instance.
So you mentioned the difficulties in communicating with families, and I'm going to have Mary talk a little bit about her efforts in that respect. But clearly that under normal circumstances is an extremely important part of the interaction that you have and the performance of your engagement with the patient. And there were obviously quite extreme barriers to doing that, at least in any traditional way. So Mary, tell us a little bit about the effort instigated by your department for this.
So part of the crisis, this pandemic, was communication. Unfortunately, the hospital has a policy of allowing no patient visitors. So patients are on their own, with the staff and the doctors, the physicians being there.
And that was not a unique
family
policy to special surgery.
No, it was not unique to special surgery. It was, it was hospital-wide and across the state. So to facilitate that, Dr. Chisholm and Dr. Kelsey, two of our physicians, had a conversation and came up with this idea of a family communications team. Our physicians and people on the front line were taking care of the patients. So we've all these other doctors, all these anesthesiologists, we'd know surgeries who were available, and some of our medical doctors. So to utilize all our resources, they came up with this idea of having a family communications team, that if your family member was in the hospital, we would have a physician call your family member at home every day at a specified time, in conjunction with one of our service excellence liaisons. So special surgery is very special, as we have a specialized service excellence department here to ensure because it's patient first, that our patient has the best experience when they come here. So we had all these ingredients in place. So it was just marrying the two together. So it was a conjunction of our anesthesia, of our physicians and service excellent, and they would reach out to the family members and be a conduit to relay information. So the family members were assured their family member, even though they couldn't visit them, was getting the best of care. They would get a daily update report on their medical, and also to facilitate if they wanted Zoom, if they wanted FaceTime, if they wanted to have a telephone conversation, if they wanted to place pictures with their family members. It just gave an extra layer of assurance to families. And that was very important also in regards to the palliative care. These are very difficult decisions to have, because I was with Dr. Rim and Dr. Hernandez during these conversations. It's when they were not allowed to visit and their family members were critical. And these are, in the best of circumstances, they're hard. It was even more difficult when they weren't able to actually see their family members.
And your sense of how the family members reacted to this service?
They were very appreciative. The feedback has been absolutely phenomenal from the family members. They just really appreciated that they felt like they had a lifeline. They felt that they had somebody there who was taking care of their family member and who was vested. And it wasn't just a doctor or a nurse, it was somebody who genuinely cared and genuinely wanted the best for their family. Because when a patient comes here, it's like our family member. How we want to get treated is how we want to treat our patients. And I think that very much came across in how our special surgery handled the pandemic or handled the influx of these COVID patients. It was very challenging across the board. We're an orthopedic hospital, and practically it felt like for me, overnight, we turned into this medical surgical hospital. And I remember this moment of clarity. I was on the 5th floor, and I was talking to Dr. Garvin, and he says, I need palliative care for room 1, 2, 3, 4, and 5. And I remember the look on my face, and he saw the look on my face. I was, oh my goodness, we really need a real palliative care service now. So it was a lot of things came forth. The palliative care service came about, plus the family medical communications team. And it was a combination of both services together that has definitely carried us through.
How did you feel, Faye, about the interaction you had and the role the family communication team played?
Oh, I think it was a great service. I think that the families were starved of communication. I kept hearing stories about how the family member had dropped off their loved one at the emergency room, and then it was almost like they were ripped apart at that point because they just were not allowed to really be with them at any other point after just kind of dropping them off. And so to have had somebody available to at least relay what was going on and feel like they could be there and be a part of what was going on, I think allayed their concern of just not knowing. I think the other problem was that these patients were very sick, and trying to convey how sick somebody is over the phone is very difficult. And so one of the things the department did, I think that was instrumental, was making sure that there was iPads available so that they could Zoom or FaceTime or do some kind of video call conferencing so that the family members could see what their loved one looked like. And see the level of nursing care that was given. So that also helped allay their fears in terms of what was going on and making sure that their loved one was being taken care of appropriately. And I think it also enabled us to then kind of move on, because we've developed a level of trust, and trust is instrumental in trying to come up with goals of care. If you don't trust your provider, how do you know that what they're saying is true? And so how do you move from there to the severity of somebody's condition and what the expectations are, what their prognosis is, and where do we want to go from there? And as Mary alluded to, those are very difficult conversations to have, even in the best of times. They were near impossible given all the barriers we had with this current crisis. But the communications team allowed it so that you built the trust, and then we would come in afterwards to really help support that next layer of decision making. They had a conduit to feel like they were a part of the level of care that was going on. And then if things were not going well, what were the decisions that needed to be done after that? And how do we help support the family members to make those difficult decisions, whatever they would be? And to be perfectly honest, I think the providers needed that support as well. These were not conversations our usual anesthesiologists and medicine doctors were used to having. And I frequently would get calls on how to even broach the subject, on what do they tell them, what can they say to not make things worse? Nobody wants to sugarcoat, but nobody wants to give away hope. And where is that fine line? And so a lot of it was just providing support to the providers and providing support to the family members, again, so that they could make decisions that were very difficult to make.
And the critical part of that was just having the same physician call the family every day. Like they spoke to the same person, so that enabled to build up trust. You didn't talk to a different provider every day, you talked to the same physician every day, you talked to the same service excellence person every day. And these relationships were building day by day, and many of them went on for weeks. So you definitely established a relationship.
So, it occurs to me as we're talking that not unique to this, but highly prevalent in this circumstance is that you often really did not have the patient's voice available to you in these decisions. And while, there are circumstances that aren't unusual where surrogates make decisions and so on, that was really the norm here. Did it seem frustrating to you to not be able to actually engage much with the primary participant in this scenario?
So the patients that were on the critical care floors, the patients definitely did not have a voice. And so a lot of the relationship building was to try to figure out what the voice of the patient would be. So a lot of the conversations were about what the patient was like before they came to the hospital, if they had ever been sick before, if they had said something, if other family members had been sick, if they had said something, and really trying to figure out, by the clues that the family members could provide, what it is that they would have wanted if they could speak for themselves. For the patients that were not on critical care, if they were lucid on any level, we did try to speak directly to them. And I think one of the movements the hospital did really early on was to try to have those conversations from the get-go. So there was a big movement on trying to get healthcare proxies and making sure that there were advanced care planning documents in place. Again, this is not something that HSS is known for doing because it's usually not necessary, but given the need and the circumstances, the nursing staff, registration, admission, service excellence, they really mobilized very quickly to make sure that everybody was well aware that these were documents that we needed, especially if things did not go well, and so that we would be able to give a voice to the patient when they still had that voice.
And the focus was always the humanity of the patient. Like, what would matter to them? What would they want? If they could speak for themselves, what would they say for themselves? And sometimes it's a hard line because the families want what they want for their loved one, but with that doesn't align itself with what the patient would have wanted for themselves in that particular time, especially with the sicker patients.
And I think that's where bioethics came involved. We frequently had to have, mutual consults for patients that we couldn't find an appropriate surrogate for. I think we had multiple conversations about patients who had living wills and trying to parse out what that means, and then kind of reflecting on that with what the family members or the surrogates were saying that they wanted to have done. So, it was complicated. But I think also, the staff across the board really kind of ramped up to learning the new lingo, like what is a living will, what is a healthcare proxy, making sure that advanced care planning documents were in place, what's a surrogate, again, it was a very steep but fast learning curve in terms of how we make sure we can appropriately take care of these patients with the voice that they did have.
So, it's obviously a very dark and difficult area of medicine, but were there any good stories? So
we had patients who did get extubated. So that was always a great day. I think there was always cheering. I think when one of the first patients we'd had got discharged, physically left the hospital, that was a good day. I myself had a patient that I was following for a very long time, ended up having to get a tracheostomy, but subsequently has been taken off the ventilator and is breathing and awake and alert. So, there are good stories in there. There are some good stories that have sadder endings, but again, I think that it's a matter of what the patient would have wanted, and also trying to create some closure for the family. We had a mutual patient. Patient had a living will, clearly documented that they would not want to be on any kind of extended life support. And so the decision was to do a palliative extubation, and she actually survived. Has subsequently gone to hospice at Calvary, but did survive the palliative extubation. We've also had some patients that did not survive, but we cleaned up the patient. We FaceTimed and Zoomed with the family members so that they could say their goodbyes. We had the chaplain come in and perform last rites that was visible to the family members via Zoom. So it was able to create some closure for them, if nothing else.
You mentioned the chaplain. We really haven't represented them, I think, so far well in these discussions. Could you just expand a little bit about our chaplaincy service and their role in the palliative care decision making?
Spiritual care is essential, actually, for the palliative care service. There is a spiritual person who's here every day. It's definitely harder via Zoom, but there always is somebody in-house, has been my experience. Sister Margaret has run a fantastic service. She's always been available. I have called Sister Margaret on the weekends, early morning, late at night, and there's always been a response. And it means a lot to the families to have that closure. They know there's somebody there. And outstanding is the spiritual care here in the hospital for all the families, because it means closure means a lot. Because when it comes to closure and saying goodbye, I have a specific case in my head as well where it meant a lot that the family were actually allowed to, just before we allowed the family to come in, very brief, because the patient we know who's going to pass that afternoon. I called the daughter a couple of days later just to check in with the family and see how they were doing. That hour or so that we allowed them to come in meant everything to them. And it was one of the most special moments. For me, it's one of the moments that really shone out. It was, for us, it didn't seem like that significant, but for them, it meant everything, because it allowed them to say goodbye, and it was special. It just meant a lot. So you can never forget the humanity and what people mean to say goodbye to each other and have that final closure.
I would also say that our spiritual care is representative of all religions. So we do have a rabbi, we have an imam available, as well as and we have obviously Sister Margaret and non-denominational Christian religions available. And even if you're not really religious but just spiritual, again, sometimes just that hand holding, having somebody who can talk to you on that level, I think helps. And
the power of media, like FaceTime and Zoom, we wouldn't be able to do this 5 years ago. So it's just been remarkable, the advent of media right now, and FaceTime and Zooming, and it's amazing. So it just brings up a little bit closer.
Well, Mary and Faye, thank you very much for this discussion, and I think it was we really wanted to feature your wonderful work in this area, somewhat unsung and maybe under the radar screen a little bit, but vitally important to the outcome for many of the patients. So thanks so much.
Thank you.
Thank you
for
very much.
your work.
Thank you.